Well, hello everybody and welcome to this episode of GUcast, one of our themed episodes supported by our gold partners Janssen Pharmaceuticals. Renu, how are you?
I'm good, Declan. It's a beautiful sunny day in Melbourne, I think. Summer is definitely on the way. We don't often do theme podcasts, but it's a special one today.
Yeah, exactly. So for those of you who aren't familiar with that, we have a partnership program on GUcast. Some fantastic partners who support the running costs of what we do, and we're very grateful to all of them. They're on our website. We'll have a link. And we have some themed episodes, and Janssen are one of our gold partners. So they're obviously interested in all things prostate cancer. We did a themed podcast on metastatic hormone-sensitive prostate cancer with them a few months ago. And today we're talking about high-risk localized prostate cancer, one of our favorite topics for sure.
Janssen have done well. Not only have they found a great topic, but also two amazing guests.
Yeah, so it's great. We're not having one of our usual guests on Zoom this time around because we've got two physical international key opinion leaders here in our GUcast studio in Melbourne.
In our humble studio.
Yeah.
It's kind of scary.
I know, it's fantastic. So it's a great pleasure to introduce and welcome our friends. I'll introduce Boris Hadaschik. I know Boris, who's a urologist for many years. He's chairman and professor of the Department of Urology in Essen, and I knew you from the days when you were in Heidelberg as well. Boris, great to have you down here in Melbourne.
Thank you, Declan. Thank you for the invitation.
Oh, it's great to have you.
And just alongside Boris is a great friend of mine and a great friend of the podcast, actually, a true subscriber to GUcast. Professor Tyler Seibert is here with us from UC San Diego. He's a radiation oncologist, a bioengineer, and a clinical translational researcher.
Oh, thank you.
Sounds really cool.
Yeah, well, this is really cool. I never thought I would be in person on the podcast. So, and big fan, can't believe I'm here.
And he, Tyler's from San Diego, so the weather we're lucky. If he'd come to rainy Melbourne, he would have just gone back, I reckon.
Yeah, we're putting his Twitter handle up there on the feed as well. But yes, he's always tweeting out these gorgeous photographs of him out for his run in San Diego, where it never seems to be cloudy or rainy. Is that fair to say?
Every once in a while. But beautiful here yesterday and today. So great runs, great photographs.
Great. Well, look, it's great to have these two in Melbourne. So they're here with Janssen Pharmaceuticals this week on an educational tour. We have an educational symposium called Prospect, which has been running for years and years, always focused on prostate cancer. And this year the theme is high-risk localized prostate cancer. So there's a dinner meeting on tonight in Melbourne. We'll have a lot of people there. And Boris and Tyler are going to talk about hot topics in high-risk localized prostate cancer. So we thought, yes, let's have a podcast about that, one of our favorite topics.
We talk a lot about metastatic prostate cancer, so it's nice to focus on the high-risk localized prostate cancer. And, it's an area of unmet need, and there's a lot of new exciting advances.
And while we got, two big experts in the area, classic multidisciplinary thing with a urologist and a radiation oncologist, we thought let's pick their brains on some of the hot topics in high-risk localized prostate cancer. Should we dive right in?
I think we should.
So we got
no place better to start.
Exactly. We've got
than imaging.
3 areas, and imaging, novel imaging to be precise. So that's the first thing we wanted to talk about, wasn't it? So what's the key question?
Yeah, I mean, we've been saying for quite a while now, the train has left the station when it comes to novel versus conventional imaging for staging high-risk localized prostate cancer, but it's not the same in many parts of the world.
Yeah, exactly right. So we want to talk a bit about the role of PSMA PET CT for initial staging of high risk, and let's include unfavorable intermediate risk prostate cancer in 2023. Now, Boris, you were on all the original papers about this. I remember it very well back in those days in 2013, I think it was, when the first papers started coming out of Heidelberg, your previous institution, about these small molecule ligands, and we saw these first images coming out of Heidelberg. So, tell us a little bit about your perspective over the past 10 years of watching it grow from this small experience in Heidelberg to now, really mass adoption, certainly in some countries like Australia.
Yeah, I mean, that's amazing. That's what you do translational science for. You start something and then you get it into the guidelines at some point in time. So it was really a happy journey, and I had the privilege to being kind of the linker between nuclear medicine and urology and facilitate some of the studies. And clearly now the Australians, you got the prospective studies done because there were some regulatory issues in Germany that didn't allow us to do prospective studies. It clearly has demonstrated superior accuracy. So it's not only more sensitive, but more specific as well as conventional imaging. So I'm completely with you. The train has left the station, and it is now very hard to do prospective studies where you decline a superior imaging modality. And so we're just writing a paper with our American friends where there has been a study randomizing patients before radiation treatment of prostate cancer to undergo PET or not, and this study had to be closed prematurely because now PET is the standard of care after reimbursement has been kind of settled in the US. In the European guidelines, however, it says clearly you should not change treatment based on PSMA PET, and we have had a lot of discussions with Nicolas Moutet, who used to be the chairman of the guidelines. Now he's not anymore, so maybe the guidelines will change, but I'm really a friend of Nicolas. But I mean, he wants to see oncologic impact using a diagnostic modality. That's a challenge, and these data are coming, but they're not there yet, and this is why the guidelines, where also Australia is involved, the European guidelines, are very strict and suggest that you are not changing treatment based on PSMA PET staging, but I guess the reality is a different one.
Totally right. So this is, and I love the EAU guidelines. We all do. Actually, they're the official guidelines of USANS here, the Urologic Society in Australia. And I love the prostate cancer guidelines in particular. They're updated every year, so they do change. But at the moment, what they say about PSMA PET CT is, number one, it's more accurate. But number two, don't change the plan based on PSMA PET CT. So we always have classic examples. So you have a patient with what looks like bone metastasis on conventional imaging. He's got an MR, a CT, and a bone scan, all showing a bone met. And then we do a PET scan. The prostate lights up, but the bone thing is a bone island. So the EAU guidelines would say this patient should have castration therapy and radiotherapy to the prostate, probably. But in actual fact, he should correctly be offered definitive treatment for localized prostate cancer. So we kind of just bang our head a bit against the EAU, your great EAU guidelines, but it's nonsensical to say don't change the plan. It would be more sensible, in my view, to say, well, be careful about changing the plan, or adopt a multidisciplinary approach, or speak to your patient about the pros and cons and the limitations, etc. But it just doesn't stack up. It just doesn't make sense for us.
I mean, here we all acknowledge that the foundation of our knowledge is based on conventional imaging. But still, we have to embrace now more accurate imaging. And roughly in this disease space that we're talking about here, unfavorable, intermediate, and high-risk disease, 1 in 6 or 1 in 7 patients does have at least pelvic nodal disease or distant mets. And clearly this changes, especially as a surgeon. I mean, I know that I cause adverse effects by doing surgery. And we have to have an informed decision-making with the patient. And I'm not going to fight radiation oncology because, I mean, if I know that it's disease outside the pelvis, then I have very little evidence that my surgery is helping. There might come some evidence that treating the primary is useful in these situations, but I think it's of utmost importance to discuss with your patient, with the best of our knowledge, what we know right now, where the disease is. Still, PSMA PET is not perfect. It's the best that we have right now, but we all know that for small nodes or small disease, it's still not sensitive enough, but you have to embrace it.
I think that's right. I mean, I think the key is you have to embrace it. And you gave an example of one end of the spectrum, and then there are the examples of the other end where, PSMA PET may show those pesky little lesions, and people believe, well, are patients missing out on curative treatment because of the scan? And that's the other dilemma.
And that's the other perspective we sometimes see, Tyler. We do a PET scan. The patient's got extensive retroperitoneal metastatic disease, not visible on conventional imaging, and people will have a view that, we're going to save that patient from futile local treatment, when actually most of the cancer is in the retroperitoneum. And I think the question changes. It's more about, well, what is the role of local treatment in someone with metastatic disease visible only on conventional imaging? It shouldn't be, let's just do what we would have done, which is just straight radiotherapy, hormone therapy, or surgery, and ignore the retroperitoneum. So what's your take on it? What's the US take on it in 2023?
I don't think I can speak for the US take, but I think we're all trying to figure out what to do with the results that we're getting. And I'm often, though I'm an enthusiast for imaging and I'm an imaging researcher, I'm often the one in tumor board saying, hey, do we know what we're looking at here, right? And it's different also, you're at the Peter Mac, you have this, you've run the trials, so you have people who are very comfortable reading, interpreting these images. I don't think that's true everywhere around the world. And I've posted things on Twitter where I said, this is a case and this came to me, it was metastatic disease, what do you think? And you get the results that you would expect. The people say it's metastatic disease, then you should escalate, add abiraterone, add SBRT to the metastasis and these kinds of things. But then the experts will weigh in. You get, the people who are very comfortable, who ran the studies for PSMA, and they look at it and say, I would not call that a positive at all.
Okay.
Right? So there's also a different, because it's a subjective interpretation, we have an issue that not everybody is going to give you the same answer. And if you're on the referring physician perspective and you get a result and you don't know how to contradict that result, you get yourself into even more trouble, right? So what do I think? I think that, yes, we need to do trials where we understand what this new prognostic information means for the patient. Absolutely, that's important. We also, I think, need to be a little bit more comfortable checking with other imaging and even doing biopsies.
If I may comment, I think it's now very important that within your team you really decide what system you use to classify the PSMA PET, what tracer is your nuclear medicine physicist using. And so now with the PROMISE version 2 criteria that have been published, it really includes certainty of the nuclear medicine physician, whether that is cancer or not. So there's a scoring now for the intensity and his beliefs, similar to PIRATES, where we have a scale from 1 to 5. It's now for PSMA PET as well. And also they already comment whether this patient could be a candidate for future radioligand therapy. This is also included now in this PROMISE version 2 framework. And I think standardized reporting now globally enables us to run really studies on a global scale and waiting for outcome. And I mean, the critique in the guidelines was we don't have outcome, but this outcome is now coming in from multi-center retrospective analysis like we did with you guys at Peter Mac, with the M0 CRPC space, but also from the registrational trials in California for PSMA 11, where they now published that yes, from the initial PSMA staging, we can predict which patients are more likely to have biochemical failure and which patients do not. So I think the guidelines, they will change because we are getting this outcome data. But a standardized reporting is now the way to go for the future.
Agreed. And to address your question about the retroperitoneal nodes, I think that's something we do need a trial there, because we don't know if they only have they have distant metastatic disease by staging, but it's node only and it's only on novel imaging. So by guidelines, I would treat the prostate and the pelvic lymph nodes, but only up to, the bifurcation and leave the rest. But now that I know those nodes are there too, does it really make sense? You could make a strong argument of just treating the prostate because they have metastatic disease. And so they fit Stampede, you're fine. But then to treat the pelvis and leave the lymph nodes in the retroperitoneum is tough for me, right? Yeah. So you could go treating all of the the retroperitoneal lymph nodes, but we don't really have evidence that that's beneficial. It just is somewhat logical if you're going to treat any lymph nodes to treat all the ones that are positive. So I tend to explain this to patients because I do not know what we should do. I'm willing to, in a very healthy otherwise patient who's, I don't know if I want to say this on the podcast, but I will anyway. If they want to, if they're very motivated, and we want to err on the side of being very aggressive, I am willing to treat the retroperitoneal lymph nodes as well. But I tell them I don't know if this is going to help you. And the more conservative approach would be to just treat the prostate. And I have patients go either way.
I mean, as a urologist, I have to acknowledge that your technique in radiation therapy has become so much better. I mean, bigger radiation fields are now not associated anymore with so terrible adverse effects that we have seen like decades ago with cervical cancer. So it really is an option. But on the other hand, we now have the systemic trials where for patients with good prognosis and good PSA response, we discuss de-escalation, intermittent therapy. So I think we know whatever we do, this patient has a very high risk of failure. So we can start with whatever, and then we discuss how's the patient doing, can we de-escalate, do we have to escalate? And I think that's a very intimate discussion in the team with the patient, and this is one of the privileges in treating prostate cancer patients because you have long-term relationship.
Yeah, I mean, I think that's right. I mean, there may not be any hard and fast rules about what you do if a PSMA PET scan is negative or positive, but the more information you get, the better chance you have of being able to counsel that patient appropriately and make some informed decisions that fits the patient, not just the disease characteristics.
And once the patients look at the scans as well, because patients want to see their scans, and if you say, well, look, that thing there, the really bright, shiny thing, that we're very, very confident that's prostate cancer, but doctor, that's not in your treatment plan, that's in the retroperitoneum, or that's here or there, and the EAU guidelines haven't caught up with that idea that the patient himself and his loved ones may have a view on, well, I can see the thing. You're telling me that this SUV max is 23, and that's definitely prostate cancer, but how come it's not in your plan? And that's why I'm really interested in Tyler's things. Well, look, I'm anxious about saying this, but we will do things now that we haven't established well over decades of randomized trials, for example, and that's use safe radiation in the retroperitoneum. But I think that's what the novel imaging does. It opens up these new questions, like, for example, what is the role of local treatment in the context of novel imaging only visible disease? What is the role of retroperitoneal radiotherapy in prostate cancer? Because I think that's a really interesting one, where you have experience of radiotherapy in the retroperitoneum for other disease areas. And, I think these lymph node only disease patients may be exquisitely sensitive to that. Surgery up there is not at all standard, and is, a totally different ballgame. I think radiotherapy would be a much more interesting question. So as a trialist as well, do you see us being able to open ambitious trials of including these M1A patients who are only visible on novel imaging in trials of local treatment to the retroperitoneum as well? Absolutely.
I think we have to, and you've got M1A. It's funny, where we draw the lines are fairly arbitrary anyway, right? Like, why are common iliac nodes distant metastases? They're in my standard field when I treat the pelvic lymph nodes, but they count as distant metastases. So why is it that if it's just below the bifurcation, then it's, you can cover that. But if you go into the retroperitoneum, but no, not anymore. Those boundaries make no sense from a radiation oncology perspective. The bigger the field, the worse, for sure. But it's not clear that there should be an arbitrary line. And in other cancers, we do extended field radiation. So it's not like it hasn't been done. In gynecologic cancers, we've been doing that for a long time. So we know we can do it, and that patients can tolerate it, and they do.
There are studies running now for metachronous disease that treat nodes in the retroperitoneum, and if these trials are positive, I think then the next step is to go ahead for de novo disease, which have higher risk of failure. So again, I think it's coming, but we start at the lower risk spectrum and then see what happens.
And I presume when you talk about that, most of these trials are going to include some sort of ADT plus AR pathway inhibitor sort of study, because these two fields are converging. You've got, local treatment of prostate cancer is now extending maybe into novel imaging identified retroperitoneal disease. And on the other hand, you have combination intensification therapy in metastatic cancer creeping back into novel imaging only metastatic disease. So there's a bit in the middle, isn't there, where it's a trial space, but also novel imaging creates this space where you're metastatic based on novel imaging. What's the role of local treatment, but also what's the role of intensified systemic treatment? Which is not curative, though. That's the big difference. But is it a adjuvant, neoadjuvant sort of?
So I think we really have to acknowledge the toxicity of ADT and intensified ADT. So there are many patients that want to delay castration or avoid it at all. And there are also trials coming up to kind of try to shorten ADT or get rid of it. And for all of this, we just need to better characterize the patients by imaging or by looking at histology a little bit better, like the Altera MMI, or other genetic tests. So I think it's really so exciting that we have the next decades in front of us where we can discuss and we get more granularity. And if we look at other cancers like lung cancer, they look at us, we have one pie and there's not a lot of personalization. And if you look at other cancers, they are a little bit ahead of us.
Yeah. And I do tell those patients, systemic therapy I think is more important for them. So systemic therapy escalation is more important, and also that I don't think that we're going to cure them. But that the potential hypothetical benefit might be that you get more time off of ADT. So we do ADT for some period of time. We don't necessarily put you on it for life. We give you a chance to see if you can go without ADT for some period of time, and maybe treating the local disease gives you a benefit. I wouldn't expect you to be able to stay off ADT at all if we don't treat all of the gross disease.
And if you ask patients, Renew, is time not on ADT a valuable endpoint? Well, yes.
Yeah, absolutely.
And we have a great podcast coming up in a couple of weeks with Tim Baker, who's been on the podcast before, talking about his experience. He wrote a great book called Patting the Shark, We did a great podcast called Patting the Hormonal Therapy Shark, and that's a really valuable endpoint, I think.
And I think, we're in this era where we're getting more and more information. I think it's important to try and minimize toxicity and overtreatment in those patients, but we want to use these imaging modalities to really identify who are those patients who have the really lethal cancers and try and intensify treatment in those patients. And I think that should be kind of our end game.
So this was the first topic, role of PSMA PET in initial staging. So
it's only taken us 25 minutes.
It's only taken 25 minutes. I'm not sure whether we quite answered it, but I think here are some take-home messages for me. What do you think, Renew? I think number one, well, there's no point sticking your head in the sand and saying, do not change the plan based on novel imaging. And yes, of course, we think everyone should be in a trial, but also be pragmatic. These scans are widely available in some countries. And, just be pragmatic about it. Don't just ignore it. And I suspect the EAU guidelines will churn a little bit. That's my feeling from speaking to some panel members, and Boris is nodding, talking about it. Who do you use PSMA PET for initial staging, Renew, just as an example of in your clinical practice?
Really, I follow the pro-PSMA criteria. So, high risk and unfavourable intermediate risk patients.
And all those patients have access to funded PSMA PET in Australia. I think I was really interested in Tyler's comments about, Boris's comments about standardized reporting. What we did show in Pro-PSMA, by the way, is there was a high concordance between the 10 centres involved and central reading. The concordance was like 0.87 or 0.9, but that's in a country where there's a lot of experience with PSMA PET CT. I think you're hinting at in countries where it's just becoming adopted or becoming available or funded. Yeah, we have to understand that there may be issues with experience. Therefore, standardized reporting, PROMIS version 2, very important. But shall we stop there on the role of initial staging? Because we got to move on. We got two other big areas we want to talk about. What's next, Renew?
Well, kind of another form of staging, really. The role of pelvic lymph node dissection when we already have such a great staging modality that is PSMA PET.
Yeah, so look, this is
it dead in the water? Is it, who does it? For us, we've moved away from that a long time ago, didn't we?
Yeah, and look, we acknowledge this is a very contentious topic, but almost all the guidelines will say in patients with high-risk disease at least, or those with a nomogram predicted probability of lymph node invasion of, let's say, the EAU say greater than 7%, I think, on the Briganti nomogram, we should do an extended pelvic lymph node dissection. But in the era of novel imaging, we've been doing this for 10 years now. And if the patient has normal-looking nodes on a PET scan, we know we'll miss small volumes. But we don't tend to do a pelvic lymph node dissection. So that's the second topic we wanted to talk to you about. We'll start with Boris.
He's already smiling. Let it out, Boris.
Well, I think it's really a controversial topic. I would ask, why did you stop doing pelvic lymphadenectomy? Now with the robot, and if you flip the peritoneum in the end, we don't see lymphoceles very often, and it's a great step of the operation for beginners to getting to know the robot, and the time it takes is half an hour maximum, so it's I think I'm not too motivated to give it up. We use the Briganti nomogram. We stopped doing surgery for low-risk disease anyhow, so it's all intermediate, and then still, even with MR diagnostics, you do have the occasional upgrading, and then you didn't do a lymphadenectomy, and then pathology comes back as 4+4, and then you think, well, now I did something against the guidelines. So it's, I think, in Germany right now, the standard of care is doing a lymphadenectomy for all cases, intermediate care and up, intermediate risk, and up. And I don't have a high motivation to change this, given the fact that PSMA PET has been shown, if you compare it to histopathology of the nodes, to be not perfectly sensitive to small disease. So it ranges from 40 to 70% sensitivity, somewhere there. So I don't feel comfortable to omit lymphadenectomy in a patient that has had a PSMA PET. And for that, he has to have high-risk disease in Germany. So I do it. And if we do in the occasional cases, if he has lymph node disease on PET and we still do surgery, then it's very often you see one node and then final pathology shows 3 nodes, or if you do salvage surgery, there's 1 node or 2, and then you have 4 or 5 in that setting. So I'm not as comfortable yet. I think for intermediate risk disease, it should be tested within a study. This study is, for example, going on in Hamburg. And then we'll find out. But for me personally, lymphadenectomy is part of the operation.
Jeez, Renew, this is one of the doyens of PSMA PET. So what he didn't say was, well, because pelvic lymph node dissection improves survival of patients or improves
so that's
their
the next question, right?
And it doesn't.
It doesn't. I acknowledge that. Yeah.
So how does it change your management though, Boris? So you've done a node dissection on a man with unfavourable intermediate risk disease. PSMA PET was negative. You found a couple of positive nodes. How does that change your management?
So if there are few nodes, I still do. I mean, adjuvant radiotherapy is kind of out. Yeah. Although Radicals RT, which will present an update at ESMO, did not include the very high-risk disease patients, but it shows that adjuvant radiotherapy for many patients was overtreatment, and so this kind of is being stopped. So if there are PSMA negative, this is a good prognosticator, and then if final pathology shows one positive node, I certainly wait for the PSA to see what we do. And on the other side, if there is a node on PSMA PET, I mean, I'm not supposed to change my plan according to the guidelines, so I do surgery, but I try to do radio-guided surgery to really make sure that I get this node out, either by visual radioguidance and then frozen sectioning, or by using some of the novel toys to get it out. And in these cases, I think it's very helpful because the Australian colleagues showed, Brisbane et al., that many of the nodes that PSMA show are outside of the classical lymph node fields. So tonight I present a case where the node is positive in the mesorectum.
Yeah.
And those are hard to get out, especially with the robot where you don't have the touch. So yes, it changes my practice, but I don't feel comfortable to omit lymphadenectomy right now for high-risk disease.
So I think that the question is, does it change management downstream, which is not actually urologic anymore? It becomes radiation, right?
Yeah.
Am I wrong? It becomes the ADT and radiation. It's the stuff down the stream. So from my perspective, is quite different actually. I don't see how it really is changing much. So if I'm the patient, I should start. We don't like to change treatment without trials to show that what we're going to do now is different or is at least equivalent to what we were doing before. And when it's something that has a survival benefit, you have to do a non-inferiority trial with a proper margin and prove that what you're going to do now is just as good. This is not, though. This is staging. This is not actually a curative therapy. It's something that's only for staging. I don't think you need a non-inferiority trial to prove that you can get rid of staging. You have something else that's good at staging. What you need is, the endpoint isn't, can you find every single lymph node in the pelvis with imaging, right? That's what we're using. We're saying the negative predictive value is like 81%. So there's 19% of patients that have node positive disease that's microscopic won't be found with PSMA. Well, who cares? Because I'm going to treat the lymph nodes anyway because the patient is very high risk, right? So if I'm going to treat the lymph nodes anyway, now it doesn't matter for a patient outcome. Is it going to change their survival? Is it going to change their duration of ADT? Is it going to what is it going to change? And in the breast cancer world, we've been down this road before. We had full axillary lymph node dissection, and then we did sentinel lymph node was good enough. And then we realized that actually, a lot of times if it's just microscopic disease, you don't even have to do anything anyway, or you have so much prognostic information from the tumor type, from the imaging, that there is a benefit of knowing something. But if you're going to then have another local therapy like radiation to that pelvic lymph node region, it's not clear to me, and you're going to do it either way. Then what is the benefit to the patient, right? I think that we need trials to do that. We did the trials in breast cancer. We need to do the trials in prostate cancer to establish the benefit of that. And if I'm the patient and you're asking me if I will consent to a pelvic lymph node dissection, honestly, right now I wouldn't, because you don't have any evidence that this additional half an hour is going to benefit me. And with all due respect, if you tell me that they'll get to be able to practice with the robot, that's not going to do it for me. It's not going to change my mind.
Right? You're right.
That won't change my mind.
Yeah. And you talked about, Renu, a bit about the example of the patient with a positive node on your pathology. But the nomograms will tell us, and there's a really nice paper from Briganti's group from Stabile and Co. in European Urology Oncology last year, a systematic review of PSMA PET for nodes. And even in that group that are experts on lymph node dissection and developed all the prognostic models, they show that there's a very high negative predictive value, especially for intermediate risk patients. And we wrote the editorial on that, and we said, okay, let's take an example. Intermediate risk patient, PSA is around 12, grade group 3 prostate cancer. Type it into the nomogram, it's like a 12% chance of lymph node involvement if we did a bilateral extended pelvic lymph node dissection. The guidelines clearly say, therefore, do a pelvic lymph node dissection. However, there is an 88% chance you do an extended bilateral pelvic lymph node, good practice, etc. There's no cancer, right? And even if there's no evidence of a survival benefit. There's clearly evidence of morbidity for some of these patients, which can be debilitating, and like 88% chance. I would find it much easier if the nomogram said, that it's 20, 30, 40%. And in actual fact, there's another follow-on paper that we were just looking at recently. I was up there recently, Giorgio Gandaglia and co, again, showing that, look, if you apply these markers and you accept a certain negative predictive value, especially for intermediate risk, you can skip lymph node dissection for a huge number of patients. So I think we need to challenge that dogma that the European guidelines has drilled into us to say if the nomogram says above this, you must do a pelvic lymph node dissection. Even softening it a bit by saying if the PET scan is negative, you can talk to your patient. We need to go back a bit and say, well, why don't we establish de novo that pelvic lymph node dissection improves survival or quality of life? Because there's no evidence it does.
That's what you need to answer. But it's interesting, again, now that in the unfavorable intermediate one is where it might actually change management. Because I wouldn't treat the lymph nodes in that patient, right? Unless their PSA is high post-op, I wouldn't, because I wouldn't be expecting that they had a very high risk of lymph node involvement.
I mean, being a surgeon, it's really, a difficult field. I mean, I see the evidence in the very high-risk disease for radiation oncology is a little bit better. We have to wait for SPCG 15 and things like that to establish a field of surgery. But if I skip lymph nodes, when I was trained, the motivation for surgery was, well, you only need one modality. You can probably skip radiation, you don't need the ADT. And then if I leave out nodes that I could take out and maybe make a difference in 10 or 20% of the patients with very limited nodal disease that can be cured by surgery alone. It's really, I think we are not there yet, but I certainly acknowledge that it is hard to argue if a patient questions the use of lymphadenectomy.
But surely even in those unfavourable intermediate risk patients, Tyler, if that patient developed biochemical recurrence, you'd be treating the nodes, wouldn't you?
And of course, that's even if the PET scan is negative. That's
Yes,
the POP
even if
RT trial. I think that's what you were hinting
Right.
at earlier. There's evidence that even if the PET scan is negative, and that's why we've really seen the inclusion of pelvic lymph nodes with radiation. It's safe. It certainly seems to have very little morbidity, and I think so. Therefore, did we need to have done a pelvic lymph node dissection to get to that point? Is there lower morbidity if you just radiate the nodes rather than us take some nodes and then radiate the nodes?
It's a good question. I mean, you'd think that there's got to be lower morbidity for some patients if you don't do something, right, than if you do two modalities. But there's the question, if we don't know, I think you mentioned SPCG 15, which is great. Is there a benefit to the patient of removing surgically the gross disease in the primary, in the prostate, if they're very high risk and you think that they might need post-op radiation? Now we're talking about microscopic disease in the lymph nodes, where if that's positive, you don't think you've cured the patient most likely anyway. So if you can find a large series and you can predict who are the patients where we take out microscopic disease and they're cured and they don't have a recurrence, then you've sold me.
That's true.
Right?
Yeah.
So, but you have to be able to predict who those ones are. Where yes, now if I go find these nodes and I cure them, but there's the thing. Most of the time, what you're doing is you're just giving prognostic information, and I think you need to make a case that prognostic information is more valuable to me if I'm the patient than if there's added value to that beyond if you do like say Decipher and Artera, right? Those cost nothing to me. I mean, they cost money, but what I mean is in terms of my, there's no toxicity risk at all. There's tissue that's already out of me that gets sent away and somebody looks at it, and you take that and you take my baseline characteristics and the clinical information that we already have and my PSA and everything, right? We have pretty good prognosis at that point. What is the marginal benefit of adding extended pelvic lymph node dissection? I bet it's not much.
I think, Boris, and you hinted at it earlier, PSMA radio-guided surgery, which I know you have an interest in. That's my take on this, is I think we are going to move from just wholesale recommendation to do bilateral extended pelvic lymph node dissection with negative PET scans and predicted 10% lymph node involvement to using PET scans and informed decision making, and then especially using things like PSMA radio-guided surgery. Yeah. So that could perhaps be the future, is that, if there's a nomogram predicted risk of 20%, PET scan is negative, well, then you're going to inject some indium labeled PSMA the day before, roll the probe around in the abdomen, and only do a targeted pelvic lymph node dissection. And if the radio-guided surgery was negative, if the trials showed that the negative predictive value is going to be, 90%, then skip the lymph node dissection. You've not just got the PET scan, you've also got some radio-guided surgery, which I think will increase the prediction. And I think patients will accept the uncertainty. So that's my view, is I think in future years we'll have moved well away from it. In Australia, let me tell you, what do you think in Australia, nobody does pelvic lymph node dissection. If the PET scan is negative, especially in intermediate risk. And there's some cases that'll be on tonight to discuss at the meeting, but for select high-risk patients, but the widespread pelvic lymph node dissection is gone in Australia years ago, I think. I'm not saying it's the right thing, I'm just saying it is what it is.
It is what it is. And it's definitely not gone in the United States. I mean, NCCN guidelines still say if there's a 2% chance, then you should do extended pelvic lymph node dissection. Now, I don't know anybody who uses that 2% threshold, so I'm not really sure why we're stuck with that in the guidelines, to be honest. But it is probably worth, you mentioned the POP-RT trial, and that they were 80% of those patients had PSMA. Those were patients getting intact prostate cancer treatment with radiation and ADT. And then it was a randomization to with or without pelvic lymph node coverage. And they had to be PSMA negative. I think that is the key thing here, though. Because of that trial, now I would treat the lymph nodes anyway. Before, I wouldn't have. So if you had asked me 5 years ago, I'd have given a different answer. Because of POP-RT, now I'm not seeing how it's changing my management. Before, finding microscopic disease in the lymph nodes was going to change how I treated the patient post-op.
Are there any situations, Tyler, in which you would treat the pelvic lymph nodes and not treat the prostate bed?
Negative margins.
No, but I don't.
Patient.
What's that?
Potent patients that we see
occasionally, because that's where the morbidity is.
I would.
That's where the cystitis is. I'm sure
I would love to. It's a great question. I think that the problem is that you always, first of all, you're going against guidelines, and then if the patient does have microscopic disease left behind in the fossa and it grows back, you've already treated all around there, and now you're supposed to treat just this one spot, and you went away from guidelines without any clinical trials saying that you can avoid it. I think you're painting yourself into a corner. But it's a good question and something that should be done on trial for certain criteria where we're very confident that the disease is not actually in the fossa.
I mean, it comes up occasionally in our MDT, doesn't it? This patient who's, is continent potent, but...
Negative margins. And it's always the urologists in the room who are saying, the problem we see years later is always because of the bed radiation. It's the stricture, it's the radiation cystitis 9 years later. Radiation trials don't go to 9 years later, et cetera, et cetera. So it's always the urologist board is saying, look, there's negative margins there, and there's lymph nodes, and can you spare the bed? Because the morbidity, whereas the pelvic lymph node radiation seems to me really safe. I've been really impressed the last 10 years. So the odd bit of late toxicity, even with good radiation nowadays, is still in the prostate bed.
I mean, the question is now, we say we want to radiate early, at least before 0.5, but then we have little chances to really see a lot in the pelvis, even with the best nuclear medicine physicians. And so then we radiate anyhow. So now, for me, the question is, what is the scenario where it is safe to wait for the PSA to climb a little bit higher until we have a target? I mean, educationally, right now, it's clear if you have a negative PSMA PET, go for the salvage radiotherapy, then you have the best prognosis, and prospectively this has been shown by Louise Emmett. And so this is safe right now, but nonetheless, I'd still be interested to find out where is it, and can we wait a little bit, and
such a great
but
question.
it's from a research perspective, it's an
and I
field.
think this is where I think PSMA PET has done a little bit of harm, is where, patients have biochemical recurrence and, the knee-jerk reaction is to do a PSMA PET, and if the PET scan is negative, they do nothing. And you lose that opportunity to salvage these patients.
And if you wait too long for the target, then that's the problem with us, with not working in multidisciplinary teams, and then suddenly the PSA is 0.9. Oh, now it's positive in the retroperitoneum.
Sometimes you see the PSA is 5, and they've lost that.
Yeah, so good point. I think it is, and I think that is one of the potential harms. We've often talked about it, haven't we? That in the salvage field, we know we don't do adjuvant anymore, but early salvage is very, very important. It's important not to turn early salvage into late salvage. So and PET scanning can kind of be a false dawn, the negative PET scans.
And we like treating microscopic disease. It's easier to kill. So
Well, it's where you can...
right, there's less cells to kill, so you just statistically you have a better chance of getting rid of all of them. I think that what I do, not shy away from, is trying to be a little bit more careful with the dose and the FOSA. So that's where it's kind of there are things you can do in terms of making that higher dose field a little smaller. Which I think we overtreat. I think our volumes have been too big. We're starting to get revised volumes now, so we've probably gone too big in the past, covering a lot of bladder and things that we didn't need to. And then there's also that we started to escalate dose for a long time based on retrospective data, and now we have randomized trials showing that really 64 was just as good as 70. So. Yeah. So I back off on the dose. I try to be more protective of that FOSA. I don't know if it's enough, but I know it's less toxicity.
So may I ask you one question, Tyler? Because I mean, now MRI is performed before biopsy in many cases. So we have the pre-treatment or pre-surgery MRI. Yeah. Are you taking this into routine consideration when you do your radiation therapy planning? Because I mean, after prostatectomy, I mean, now the anastomosis is somewhere else where the positive margin might have been. So I think it's a challenge to really delineate the field. And so do you take care of the MRI from before or not yet?
Not really yet. I would like to. It's a good point. And if you could, it would also be helpful if we always knew where the positive margin exactly was and where the extra prostatic extension really was. And if that corresponded to where it was on the MRI. That would be helpful information, I think, and then you could reasonably try to adapt. But of course, where the prostate was is now gone, and everything has moved, so it's hard to have confidence that you know exactly where that positive margin was. Unless you can tell me it was fixed to the anterior wall of the rectum and it was right there, and you put a clip on it, and, then is a different story.
Yeah.
So Renu, we've indulged ourselves a bit, but we got one last topic before we got to get out of here.
It's a great topic.
It's a great topic.
We have to cover that.
So go, shoot.
Optimal radiotherapy strategy in 2023. What we wish we knew in 2022.
Yeah.
So Tyler, you're up.
So many things we talk about it all the time. Hypofractionation, PACE-B last weekend. I know. Hypofractionation.
In San Diego.
In your hometown, Estro and Nick van der Aas. So that's really exciting. So that's popular with patients if you can deliver radiation in less fractions, etc., with good toxicity, duration of ADT, Artera, etc. But, can you briefly summarize it in the last few minutes about where are we? What are the key things you do routinely in your practice?
Summarize in 2023. Radiation is amazing for prostate cancer in 2023. That is the take-home message. No, I think there are a few things that have changed, right? We have hypofractionation, which is mostly a convenience issue. It's also a cost issue. Depends on where you practice, how that plays into, whether it's more cost effective to do SBRT or more cost effective for the physicians or the hospital, right? So
So just explain, that's because it's often reimbursed as per fraction. So there can be a penalty to the institution. And so I think it's the same in Australia, actually.
Or to the private, private radiation oncology. So it's a strange thing because in the UK, there's a resources limitation. So getting everybody done in 5 fractions would save a lot of resources and get more patients treated. And Nick was telling me in San Diego over dinner that it was going to save, and I won't say the number, but it was an enormous amount of money that it would save NHS England to switch everybody to 5 fractions. Wow. Mind-boggling number. So that's compelling, right? If you're in the United States, when I'm treating patients, it doesn't matter to me. I mean, 5 fractions, 28 fractions. It doesn't affect my bottom line. If you're a private practice, it does, because you need to be able to keep the doors open for everything that you're doing. And unfortunately, we're treated paid per fraction. It's not necessarily making a whole lot of sense. But then there's the issue, though, that which patients actually would be better with more fractions? There probably are some. Even in the UK, patients with more LUTs are, above some threshold are going to get more fractions. How do we decide who should be able to tolerate more side effects and who shouldn't? I don't think we quite know. We know that it's safe. You can do it. I always tell patients a very small difference in side effects to go faster. So we'd never treat 9 weeks anymore, which is what I was trained to do when I first started. We don't.
And the
necessarily
machinery
define-
is the same. You don't,
Yeah.
standard modern Linux can hypofractionate. You don't need a cyberknife or a.
No, you can use
STX.
modern treatment machines can do all of them, and it's not harder to do technically either anymore, really. So it's perfectly fine. It's a big win for patients, and it's a great tool to have in our toolbox, and I love to use it. I think more interesting though is actually, I guess it's very good for patients, but it's not super exciting because we already kind of expected that was going to be the case for a long time. So what's more exciting is focal radiation boost to the MR visible tumor. That's exciting. Adding the pelvic lymph nodes and knowing that it helps, because before we used to kind of argue about it, but we had no idea if it really helped. So it was unsatisfying. Now
This
we
is
have
for the N0 patients.
Yes, for
high risk or predicted risk or PET scan.
Pop RT patients.
Okay.
So node negative on PSMA. Now I have a reason to treat the pelvic lymph nodes. And between that, first the focal radiation boost from Flame and Pop RT, we've seen just big improvements. We also have a better understanding from the Mirage trial, which was an SBR3 trial as a MR Linac versus CT based. That was fantastic. Not even only because look what you can do with an MR Linac, but just realizing that a 2 millimeter change in your margins makes a meaningful difference in toxicity for patients. That was eye-opening for me. And it's all the more motivation to use MRI in your treatment planning, because not only does it allow you to do the focal boost, but it also just allows you to see the boundaries of the prostate. And on CT, we could talk for a while. I could show you all the studies where we see how when you're on CT only, you don't actually hit the prostate very well, and so you end up over-contouring and spreading high dose beyond the prostate boundaries for really no reason. That's another eye-opening thing. It gives you a real reason to do the MRI-based planning, which is something that, again, we used to argue about, but we weren't really sure if it mattered. It clearly does.
Brilliant.
And what about, just quickly, the use of ADT, duration of ADT? How has that changed?
Is changing. For post-op, it's kind of a mess, right? Because we have a few trials that show that ADT matters. The best evidence of a hard endpoint like metastasis-free survival, it comes from radicals, and there you're looking at 2 years was what came out positive, which is painful. Yeah. It's painful to think that you went through surgery with the idea that maybe you could reduce your need for or duration of ADT, and now you might be looking at 2 years anyway. That hurts. So I'm not excited about that. I think we need to clear up that picture. Who really needs what duration? We rarely do 2 years. Yeah. And then in the intact setting, I'm sure that we are doing too long for too many patients. So I would love to see these trials that are coming up. What about something that's short term but more intensity, like Formula 509, which was done in the post-op setting, 6 months, but you add a second or a third agent. In that case, it was 3 agents, ADT plus 2 others, but probably you just need 1 other. So if you add abiraterone, apalutamide, enzalutamide, or something to your ADT and you do it for 6 months, is that good enough for a lot of patients? And we're also doing trials right now that I think are very interesting. It'll take a while to read out, but they're accruing like crazy in the US and elsewhere, is trials looking at stratifying based on molecular tumor markers. So if we do look at Decipher, if they're Decipher high, we randomize them to escalating the systemic therapy or not. If they're Decipher low, we randomize them to shortening or omitting the ADT altogether.
Yeah,
those will be great for patients.
More de-escalation trials. We love
Definitely,
that, don't we?
Yeah.
Fantastic.
Wow.
It's almost a breathless amount of work.
Do we have to stop?
I do, because they have got to go. You know,
to go.
there's a
I have
big education. I mean, you're chairing the meeting tonight. Yeah. So, yeah, look, that's great. 3 topics.
Yeah.
I hope the audience enjoyed that. I certainly did, but I feel like I've just got another 20 questions to ask. But that might have to be another time.
It's a
or
great
dinner.
discussion.
At dinner tonight. Exactly right.
Exactly.
Yeah, Boris,
Alright.
thanks. Any finishing comments for you? Great to have you here in Australia, and I hope you're enjoying yourself.
Yeah, thank you for being here, and keep on the great work.
Fantastic.
Tyler, same to you. Thanks for being here, and wonderful to have you in Melbourne.
Thank
Great,
you.
great.
Truly an honor.
Fantastic. Well, that's all we got time for on this episode of GUcast. It's been really good to have these expert key opinion leaders in town. Thank you very much for your support, and thanks very much to Janssen in particular for supporting this themed episode of GUcast. They're our gold partners, and thank you to Janssen for supporting these high-value educational activities, and to all our partners for supporting all we do in GU Oncology. That's all we have time for. We'll be back again soon. Thank you very much.